Good morning. Today we'll be concentrating on aminopenicillins and other extended spectrum penicillins. Already you have some idea about penicillin and the limitations of penicillin preparations. So one of the most common limitation of penicillin G is its spectrum. It's basically a narrow spectrum antibiotic. So in a way to increase its spectrum, some modifications being done in structure so that the synthetic preparations are available, and those drugs are basically working on broader spectrum, or more specifically it should be termed as extended spectrum. So aminopenicillins like ampicillin, amoxicillin, a prodrug of ampicillin is talampicillin, bacampicillin, and these kind of another drug is pivampicillin. All of them are extended spectrum antibiotic. Though I have mentioned so many names in the initial slide, but we will only concentrate on amoxicillin and ampicillin while discussing aminopenicillins, because these are the two drugs which are commonly used in clinical practice, and you will see the adverse drug reactions and different action of these drugs on different organisms. When I compare amoxicillin and ampicillin with anti-staphylococcal penicillins, or rather the natural penicillins, spectrum is coming first, and spectrum is definitely increased with amoxicillin and ampicillin. So it's a comparatively wider spectrum or extended spectrum penicillin. And this has been mentioned in the following slides at broad spectrum penicillin, though I think the term broad should not be used in case of aminopenicillins. And their susceptibility, these aminopenicillins are pretty much susceptible. It is not like the penicillin is resistant penicillins, so they are susceptible to all the bacteria which are responsible for synthesis of virulent enzymes like beta-lactamase. The aminopenicillins have identical spectrum and activity, but if you compare these two, then amoxicillin is probably absorbed better in the oral form, and amoxicillin has certain advantages over ampicillin. We will again discuss it in the later slides. In order to increase the range of activity, the penicillin has been modified to have more hydrophilic group. That means which are having affinity towards water, and it's allowing the drug to penetrate into gram-negative bacteria via the porine channels. What was the limitation of natural penicillins? Those are predominantly active on gram-positive bacteria. But here these aminopenicillins are not only active on the gram-positive, but their spectrum is increased towards gram-negative bacteria. Obviously, the Pseudomonas is not going to be affected by ampicillin or amoxicillin, but the other ones like E. coli, Klebsiella, then your Szella, these kind of organisms will be definitely not resistant to ampicillin or amoxicillin. Ampicillin is basically a water soluble and acid resistant antibacterial drug or penicillin group of drug. Its antibacterial activity is generally similar to that of benzyl penicillin. In addition, it is highly effective against few of the gram-negative bacteria, as I told before. It is effective against Proteus, Neisseria gonorrhoeae, Salmonella typhi, Haemophilus influenzae, and several strains of Shigella. Now, its effect is moderate against Klebsiella. Certain strains of Aerobacter and Enterococci are also involved. Ampicillin is inactivated by beta-lactamase. So, chance of resistance due to beta-lactamase forming bacteria is always there in case of ampicillin as well as amoxicillin. It is ineffective against Staphylococci, resistant to benzyl penicillin most of the times. Bacteria can develop resistance to ampicillin, as I mentioned before, and many strains of Salmonella, Shigella, E. coli and Proteus also shown their resistance towards this drug. It is incompletely absorbed on oral administration. That is the primary limitation of ampicillin, and that is the reason why amoxicillin is scored over ampicillin in clinical practice. The portion not absorbed in case of ampicillin is inactivated by beta-lactamase of the colonic bacterial flora, and hence this drug rarely produces superinfection in contrast to tetracyclines. So that is in another sense a kind of advantage of giving ampicillin rather than a broad spectrum drug like tetracycline. The chance of superinfection is very little with ampicillin. About 1/3 of the dose is actually excreted unchanged in urine, and high concentrations are present in the bile. So, in premature and very young infant, excretion of ampicillin is delayed. It crosses the placental barrier and achieves therapeutic concentration in the amniotic fluid. So, you have to consider this, though these amoxicillin and ampicillin, rather as a whole the penicillin group of drugs, they are more or less safe in pregnancy. They are called pregnancy B drugs. The common adverse drug reactions which we encounter with ampicillin: skin rash and maculopapular rash, urticarial, and sometimes if ampicillin is given during the onset of fever and sore throat due to infectious mononucleosis, you see a typical type of ampicillin-induced rash. Diarrhea is common with oral ampicillin and its derivatives, and hence amoxicillin is always preferred over this. Normally it is available in the capsule form containing ampicillin hydrate equivalent to 250 mg of the base. The usual adult dose by all route is around 250 to 500 mg 6 hourly. Doses as large as 1 gram 6 hourly may be required for more refractory gram-negative infections. As I told you before, the therapeutic window for any penicillin preparations are quite wider. Hence, we can always prescribe the double dose. That means doubling the dose from 500 to 1 gram will not show you any kind of dangerous side effect. Obviously, the chance of seizure is still remaining if it causes CNS toxicity. In children less than 13 years, the daily oral dose is around 50 to 200 mg per kg of body weight. Stability of ampicillin sodium in solution decreases markedly, and storing of solutions even at refrigeration temperature results in deterioration of activity. The presence of dextrose and lactate accelerates its loss of potency. Now, ampicillin should not be combined with aminoglycoside group of drug like gentamicin and amikacin in a single syringe. There is always a chance of in vitro drug-drug interaction. They will destroy each other's effect. So, in vitro means outside your body, and you should not draw ampicillin in the same syringe with gentamicin. So separate syringes are required for giving ampicillin separately and any group of aminoglycoside like drug in a different syringe. Therapeutic uses of ampicillins are urinary tract infection, respiratory tract infections, meningitis, biliary tract and intestinal infections, and it is preferred to tetracyclines in pregnant women and in infants. Because of increasing resistance by bacteria, ampicillin has lost its status as a drug of choice for the empiric treatment of childhood meningitis, salmonella, that means enteric fever, seizurlosis and gonococcal infections. Amoxicillin is always preferred over ampicillin because it can be given orally. It has a better half-life of around 8 hours, so 3 doses of amoxicillin are sufficient. We already got a combination of amoxicillin and clavulanic acid, which are basically corresponding with each other in terms of pharmacokinetics, as well as it has been seen in clinical trials. These kind of preparations are very effective. Ampicillin also can be combined with sulbactam-like preparations. So mostly the patients prefer the oral preparations. The patient compliance is better with amoxicillin. As the oral formulation of amoxicillin is better than ampicillin, amoxicillin is always getting edge over ampicillin in clinical practice. These drugs are effective against streptococci, enterococci, and as I said, some of the gram-negative bacteria. And obviously, in peptic ulcer associated with H. pylori regime, you can give amoxicillin with other drugs like omeprazole and clarithromycin for 7 to 14 days. So that is one of the characteristic feature of this aminopenicillin group of drugs. We will come to the discussion of amoxicillin a little bit later. So these penicillin should be termed as extended spectrum penicillin rather than, or wider spectrum penicillins rather than broad spectrum penicillin. Now when we compare it with penicillin G, that means benzyl penicillin, we are seeing that they are less sensitive towards B. fragilis. They are sensitive, more sensitive towards meningococci, Neisseria meningitis, Listeria and H. pylori. Their sensitivity is partial towards pneumococci, Haemophilus influenzae and streptoviridins. We are seeing increasing resistance against Proteus, E. coli, Salmonella, Shigella, Neisseria gonorrhea in case of, mostly in case of lactam, beta lactam is producing bacteria. So if you are specific about your diagnosis via culture sensitivity, the use of amoxicillin and ampicillin are become limited in these situations. Always you see the antibiotic susceptibility chart or the report, and you see R stands for resistance written just beside amoxicillin and ampicillin both. And as we all know, these are never been active against Pseudomonas. So later on we'll see that there are some penicillins which are having better spectrum than aminopenicillins, invented as they have a specific activity towards Pseudomonas aeruginosa, Serratia, indole positive Proteus, specifically Pseudomonas, and those penicillins are actually known as anti-pseudomonal penicillins. So these penicillins, aminopenicillins, which include ampicillin and amoxicillin primarily, are extended spectrum penicillin rather than broad spectrum penicillin. The term broad should only be used in case of chloramphenicol and tetracycline. Amoxicillin has certain advantages over ampicillin, which I discussed previously. It's basically a structural analog of ampicillin and has properties uses similar to those of ampicillin, but with certain advantages. The first advantage is it is completely absorbed, and the blood levels on oral administration are twice as high as those of ampicillin. So oral preparations of amoxicillin is better than oral preparation of ampicillin. Its absorption is not influenced by food. So amoxicillin can be taken irrespective of the fact that a patient has taken food or patient is in empty stomach. The drug amoxicillin is less protein bound and the urinary excretion is higher than that of ampicillin. The chance of diarrhea is lesser than ampicillin. As we are preferring the oral dose of amoxicillin, we know the patient compliance is going to be better. The T half of amoxicillin is around 8 hours, so it can be given 3 times daily, whereas ampicillin should be given 4 times daily. So lesser dose is required in case of amoxicillin. But amoxicillin is more expensive. It is available in the 500 milligram tablet form, or it is depending if you are prescribing it in children, then 25 to 50 milligram per kg of body weight. Dose should be prescribed in case of respiratory tract infection, acute sinusitis, or otitis media, or even case of specific infections. So it is depending on the severity of the infection, on the basis of which the dose range is from 25 to 50 milligram per kg of body weight in case of children. And mostly in adults, 500 milligram 3 times daily tablet or capsules are given, and this 500 milligram can be replaced by giving 1000 milligram preparations, twice daily formulations. Most of the times we are getting formulations where amoxicillin is combined with a beta lactamase inhibitor known as clavulanic acid. So amoxicillin clavulanic acid combination can be given 3 times daily, or it can be given twice daily. Dose remains same, but in 3 times daily the dose is going to be 625 milligram, because 500 milligram of amoxicillin is combined with 125 milligram of clavulanic acid, whereas in case of twice daily formulation we are seeing that the same 125 milligram of clavulanic acid is combined with 875 milligram of amoxicillin. But patient compliance is definitely going to be better in case of the formulations which are prescribed twice daily. These extended spectrum penicillins are basically given in case of dental prophylaxis to prevent infective endocarditis. It is 1 gram per orally 1 hour prior to dental surgery, but you can start giving these preparations in the oral form for 2 to 3 days so that it reaches its therapeutic concentration, and after that you can go for dental extraction. And in some book you will see that amoxicillin 2 gram per oral dose, instant dose, was given 1 hour prior to appointment of or for preparing the patient for dental surgery to prevent infective endocarditis. Very rarely it's combined with the drugs like aminoglycosides. And if the patient is having some problem with amoxicillin, in that case the macrolide should be preferred. It is either erythromycin mostly, or even sometimes vancomycin can be given. It's an integral part of H. pylori regimen, as I mentioned before, and it is prescribed with clarithromycin and any one of the proton pump inhibitors, most commonly omeprazole or pantoprazole. So this slide has already been discussed, the advantages of amoxicillin over ampicillin. So respective comparisons are being shown in this slide, and just have a look at this so that you can recapitulate whatever I said in the previous slides. Now, the limitations of these penicillins are plenty, but I'm just highlighting two over here. The first one is they are not resistant to beta-lactamase, and the second one is spectrum is broader or wider in comparison to penicillin G or natural penicillins, but still there are some bacteria, dangerous bacteria, which are not affected by these penicillins, and those one of the most common bacteria is Pseudomonas aeruginosa. Now, anti-pseudomonal penicillins are those penicillins which include primarily Ureidopenicillin and part of Carboxypenicillin. So these drugs retain activity against streptococci, poses additional effects against the gram-negative organisms, including various Enterobacteriaceae and Pseudomonas, but they are all labile to beta-lactamases. So they are also susceptible to beta-lactamase. The beta-lactamase preventing activity is not existing among these kind of penicillins. Their main advantage is extended spectrum. Even it's more extended in comparison to aminopenicillin. These extended spectrum penicillins are similar to the aminopenicillin structure, but have either a carboxyl group or a urea group instead of the amine. So that is the one difference, which is a little bit of difference in the side chain, which is basically making this one effective against more gram-negative bacteria, including Pseudomonas. These drugs also have difficulty in penetrating the gut wall, but can be administered intravenously, and it's not available in the prodrug form. They are susceptible to beta-lactamase, and that's the reason why one of such drug, Ureidopenicillin, that is piperacillin, can be combined with another beta-lactamase inhibitor, tazobactam. And when we are talking about piperacillin and tazobactam, we can prescribe this combination in the injectable form, because this combination is showing effectiveness in the clinical trials, as well as they are compatible in terms of pharmacokinetic parameters. So whenever you combine any beta-lactamase inhibitor with any extended spectrum group of penicillin, you have to see whether they are compatible pharmacokinetically, as well as you have to see whether this combination is getting adequate, successful clinical trial report in favor of this combination, and only then we can combine a specific beta-lactamase inhibitor with one of those penicillin preparations. It means that amoxicillin cannot be combined with tazobactam, and it also means that piperacillin cannot be combined with clavulanic acid, because they are not compatible in the pharmacokinetically, as well as this kind of combinations are not successful in clinical trial and clinical practice. The extended spectrum penicillin, first one is carbonicillin. It's a similar spectrum but a little bit weaker antibacterial activity than ampicillin. Its important advantage over ampicillin is it's effective against all strains of Proteus and Pseudomonas aeruginosa. It is administered via injectable route, as I said before, and its peak levels are reached around within 2 hours, and the drug is eliminated in urine within 6 hours. Carbonicillin is present in the carbonicillin sodium form, and it contains a huge amount of sodium, not like penicillin sodium form. In penicillin sodium form or in penicillin potassium form, the amount of sodium potassium concentration is lesser, but in case of carbonicillin sodium, it contains a huge amount of sodium. Hence, this should be avoided in a patient suffering from heart failure. This large sodium content may lead to precipitation of the same. That means a congestive cardiac failure, or if the patient is in stage 3 heart failure, you should not prescribe 2 or 3 heart failure. You should not prescribe a drug like carbonicillin. The better anti-pseudomonal penicillins are available in the market. It is undergoing a rapid ester hydrolysis in blood. It is acid stable. Orally only used in UTI, not in other cases. The other ones like piperacillin, ticarcillin and agglocillin, these are additionally active against selected gram-negative bacteria such as Klebsiella pneumoniae, different strains, bacteroids, non-beta lactamase enterobacteria, enterococci, and piperacillin has the broadest spectrum among all penicillins in combination with tazobactam, as I mentioned in the previous slide. So the broadest term should be replaced by term extended. The most extended spectrum penicillin is piperacillin. Piperacillin is basically a ureidopenicillin, and its activity, as I mentioned, against gram-negative bacilli, but we are emphasizing Pseudomonas aeruginosa as it is also a kind of penicillin which is known as anti-pseudomonal penicillin. Usually 3 times daily dose is given in combination with tazobactam, but in some clinical trials it has been seen that piperacillin alone is giving almost as good as a result in compared to piperacillin tazobactam combination. Piperacillin is given parenterally. It is mainly eliminated in the urine, almost 90%, and its adjustment of dose is needed in the presence of renal damage. Piperacillin crosses blood-brain barrier and may be useful in neonatal meningitis. Adverse effects are similar to those of other penicillins, however, it is less likely to cause sodium overload, and hence it is preferred over carbonicillin-like drug. It is useful in a variety of infections. Its use should be reserved for serious infections such as Pseudomonas aeruginosa, which means it's a better penicillin and you shouldn't charge it in a simple case of upper respiratory tract infection or in a case of UTI. This should be kept as a reserve drug. Obviously, the patient compliance is not going to be good because it is given via injectable route and mostly intravenous route. Sometimes you may prefer the intramuscular route. There is another term, that is called Amidopenicillin, and such penicillin is mesillinum, and it has no therapeutic activity against gram-positive organisms and only effective against gram-negative organisms such as E. coli, Klebsiella, Shigella, Salmonella. Protease is less susceptible, and mesillinum has no action on Pseudomonas. It is poorly absorbed orally and given via intramuscular route. Its ester is pivmesillinum, Pivmesillinum is the spelling of pivmesillinum. It is better absorbed orally and it is hydrolyzed to Mesillinum. These compounds have been used in UTI and in typhoid fever, but do not appear to be superior to other commonly used drugs. Hence, you just have to remember the name, but you must also remember that Mesillinum is not commonly used in clinical practice. So I am ending this slide with the last one, that those supportive clinical data are lacking for superiority of combination therapy because of the propensity of Pseudomonas aeruginosa to develop resistance, and anti-pseudomonal penicillin is frequently used in combination with either aminoglycoside or fluoroquinolone for Pseudomonas infections outside the urinary tract. So it's always remember that though it is covering a huge spectrum, but the clinical decision is not always depending on what is written in the book. Rather, you should follow book, but you must remember that these kind of things is happening in clinical practice, and by observations when adequate data is coming in our hand regarding a combination of piperacillin and any of the aminoglycoside like amikacin is only proven to be more effective in certain conditions, or a combination of levofloxacin from the group of fluoroquinolone or ciprofloxacin with piperacillin or amoxicillin type of drug is rather piperacillin is more effective in pseudomonal infection. You should follow that regimen. That's the end, and in the next class we will probably discuss the adverse effect of penicillins. Thank you.